Hello, everybody. This is Sam Realista. I am presenting the mechanical ventilation case study number 6 for the adult gerontology acute care nurse practitioner NGR 6210 with Dr. Blackwell, our professor, and everybody else. Welcome. Thank you for joining me. And I just wanted to point out that if you have any questions throughout this presentation, that you can feel free to write them down and email me at srealista@knights.ucf.edu, and I will personally answer them as fast as I can, and we'll get back to you as soon as possible. So I have no disclosures, so it's a very simple presentation, and here we go. So my topic is hypotension. So what is hypotension? This is an important topic to discuss because based on the case study that I have, we will go over it at this point, and then we will discuss the questions that were assigned to me and what is important to look for with this topic. So our case study deals with a 65-year-old woman intubated emergently for a severe COPD exacerbation. She underwent a rapid sequence intubation including succinylcholine for paralysis and etomidate for sedation. Shortly after intubation, she becomes hypotensive, with her blood pressures dropping from 145/85 prior to intubation to 95/60 post-intubation. On exam, she was very prolonged in expiratory phase and diffuse wheezing. So you can see a picture there of a heart that is attached to a sphygmomanometer and that reads 90/60 millimeter mercury. So hypotension is when you have low arterial pressure that's registered on a meter or a hemodynamic instrument that is a lot lower than what is normally found in an individual, in an adult. So my differential diagnosis includes this list of things that I thought about for this individual, this older adult lady. She's obviously a younger, older adult. She's 65, but these things popped into my mind. You know, we have adrenal insufficiency. I'm in nephrology, so this thing, of course, is first on my list. There's oversedation with the medications involved. Aspiration, of course, during intubation, as you see the picture there, aspiration can happen. Septic shock, there is pneumonia, and there's a combination of meds, as already mentioned, succinylcholine, paralysis, and etomidate for sedation. And of course, we have to consider the increased PEEP and the setting, and that's PEEP stands for positive and expiratory pressure. We want to start patients, especially with COPD, with a low PEEP, and that's found in our Cairo book. And mechanical ventilation with ET tube placement, we always wonder, is it in the right place? And we also wonder if the ejection fraction is also a factor if this patient has cardiac history, but the case study did not mention any history of cardiac history. Intrathoracic impedance, pulmonary hypertension, chemical exposure, long-term smoker, and is there any laryngospasm that's blocking expiration? So there are factors that lead to the findings. So the first factor is the timing, it was very rapid, right? We were told that she underwent rapid sequence intubation, and shortly afterwards, after intubation, she becomes hypotensive. So timing is very important here. We're seeing about, maybe I would imagine, between 15 to 30 minutes. That's for these medications to act. It's very rapid. The second factor are the medications involved. So we've got a paralytic and then a sedative that's used in anesthesia, actually, in emergency rooms. And then the third factor is it occurred right after intubation. So there are several things that happen after paralysis. Of course, we're inserting an endotracheal tube. It did not mention an ET tube, but we're assuming that it is. The fourth factor is this patient's comorbid or existing diagnosis, which is a severe COPD exacerbation. And that's probably the chief complaint there. So, and protection of airway. The fifth factor is the age, right? Sixth factor is the gender. So this is a female. Seventh factor is the severity of hypotension. How severe is it? Well, it dropped significantly from 145/85 to 95/60 post-intubation. And the eighth factor is prolonged expiratory phase with diffuse wheezing. So diffuse wheezing is found in COPD, especially if it's really severe. And the prolonged expiratory phase, well, that is found with outcomes of these medications that were administered. And they are the succinylcholine and etomidate. Now, these two medications, there's pictures of them. They come in different, vials, different volume and dosage. The paralytic and sedation are both administered together, and they are usually, normally, routinely administered together during intubation, especially in the emergency room. We know that etomidate, we have to focus on this drug because this drug was originally used as an antifungal in 1965 by Janssen Pharmaceuticals. The onset, as you can see there in that chart, the onset is fast, the duration is short, and there are no cardiovascular effects, which is good. It does decrease respiratory effects, which is good. And analgesia, has no analgesia, and mild amnesia that's noted. And there's a list of all these medications, and these are all hypnotics as well. There's propofol, ketamine, I'm sure you've heard of those. Midazolam, that's used in ICU. And dexmedetomidine. So oversedation with etomidate we have a study here that was compiled, 397 patients studied at Rush in Chicago, divided into two groups using etomidate in the emergency room, midazolam or propofol in ICU, and both resulted in similar outcomes with SOFA, sequential organ failure assessment, and RASS, the Richmond Agitation Sedation Scale. Etomidate prior to intubation, we've got an association with increased odds of oversedation following intubation, according to Sarigianis. Etomidate sedative-induced events were also recorded in South Korea. There's a graph of increasing events related to oversedation from this medicine. As you can see, since 2008, 2009, right there, not much of a difference, but then there's a big leap in 2010, and since then has been increasing up to 2017 recorded of sedative-related adverse events in this 10-year study by Choi and et al. So how do we manage hypotension between paralytic and a sedative? Well, we have to bolus right away. So according to our textbook, Lau, hemodynamic monitoring involves, especially a drop of significant pressure in hypotension, we bolus IV normal saline. And we first determine if there's bleeding involved. So that must occur first prior to administration of bolus, because administration of bolus with bleeding can actually increase bleeding. And we don't want to do that, so we want to determine if there's any bleeding involved. Maybe CT scan is definitely in order of the abdomen. Then we apply Foley for output monitoring. So then we do strict intake and output, and we find that balance. Obviously, this patient's going to be initially positive in the beginning in terms of fluid balance, but that's okay because we want to raise that blood pressure using fluids. We want to do chest x-ray to make sure first if that endotracheal tube is in place appropriately, and we want to make sure if there's any pneumonia or any type of abnormal findings there. If there's any inhalation or any toxic remnants that's found in the lungs. We also want to do sepsis workup because we want to make sure that this is not a result of sepsis. Now, sepsis can happen rapidly, but in this time here with COPD, sepsis might take a lot longer. So that's why I believe that it's not related to sepsis. We also check for sodium, cortisol, and TSH. And then if it's unresponsive to bolus IV fluids, then we use depressor. And we always have to have Levophed handy before we intubate. That is always a rule in ICU. We use norepinephrine to raise the blood pressure. And then we always have that bag before intubation. And we allow the patient to stay off sedation until that patient, he or she, in this case, she, I misspelled it there, recovers. And then we start IV sedation for comfort and vent synchronization. We wait until she passes the half-life of the medication, and then once the pressures are stable, we wean off depressors. And that's found in Marino in our book, 2014. And that is it. That is my reference page. If you have any questions, feel free to email me. Again, thank you so much for your time, and I hope that this was beneficial. Thank you very much.